We are going to continue our session, and thank you, Dr. Tiwari. Please join us here. Dr. O.P. Yadav to continue here. Dr. Surendranath Khanna, he is a cardiovascular surgeon from Max Hospital. If he is here, please join us here. The next session is going to be important, and Dr. Praveen Chandra from the Medanta group. He has just joined from Max to a Medanta group as a interventional chairman interventional cardiology. And the session is going to be moderated by Dr. O.P. Yadav, a cardiothoracic surgeon and the head and the CEO of National Heart Institute, and Dr. Surendranath Khanna on the subject, what's new in interventional cardiology. Dr. Yadav to start.
Good morning to you, ladies and gentlemen. It's a singular pleasure to present to you one of the dons of Indian interventional cardiology, Dr. Praveen Chandra, to give a talk this morning on the interventional cardiology scenario. I suppose he's going to concentrate on India and what's happening in the city of Delhi. So, ladies and gentlemen, presenting Dr. Praveen Chandra.
First of all, I must thank Dr. K.K. Agarwal for giving me this opportunity to talk about the advances and what we are doing as cardiologists and as interventional cardiologists these days. And I must thank Dr. O.P. Yadav for the kind words. And I have Dr. S.N. Khanna also here. So this is quite interesting that cardiologist is speaking and cardiac surgeons are watching. So I'm a little scared, but anyway. So, friends, what I'm going to do today is to tell you what we are exactly doing, because the scope of cardiologists have actually changed a little bit. They have moved from the heart up to the brain and down to the vessels of the lower limbs and also in the abdomen. So we are almost taking care of everything which actually involves the heart and the blood vessels. So first of all, there is a good news that we are living longer, and thanks to the change in technology and the drugs and everything which is leading us to live longer. And as you can see here, that over the last so many years, the life expectancy has improved. And it has not happened automatically. It has happened because of advances which have really changed the way we started practicing medicine and cardiology. So at the same time, people will say that if the life expectancy has improved, why worry about cardiovascular diseases in this day and age? But let me tell you again that still the major cause of death is cardiovascular diseases. And then comes cancer. So that is why we are talking about cardiovascular diseases. It is striking the young patients, middle-aged individuals, and the people who are very active, they get affected by cardiovascular diseases in their prime time. When they are really very active, it starts affecting these individuals, and that is why we have to start worrying about them, start treating them, and preventing those morbidities and mortalities which occur because of this problem. So what is the common thread? Why does this happen? And the common thread is that the circulatory system, and that is why the cardiologists have moved from the heart to the entire circulatory system, and that is the arteries and the veins. Because the common thread is atherosclerosis, and that is why the interventional cardiologists have moved from the heart to the entire body. And we have started knowing that atherosclerosis, which was only the term which was used when we were in the second year or third year, that it is a pathological term, and we only see the specimens in the pathology labs. But let me tell you, we have started treating atherosclerosis now by very effective medicines and by interventions all over the body. So first of all, let me take you to coronary intervention. That is where we started. That is where intervention started in the vascular system. And the heart was the first, vessel, the organ where we started doing interventions in the coronary arteries. And this is what we actually started with. Because you must be wondering as to how do they do this intervention. So let me show you. These are the fine catheters which we use, the wires which are very thin wires which we take inside the arteries. This is how a balloon looks like. The balloon which is expanded inside the artery, and this is what you very commonly hear these days, that the stenting has been done in a particular patient. This is a stent which is mounted on a balloon, and this is an expanded stent inside the artery. So that is how we treat these patients, and this is a drilling device which we use in those patients where the blockages or the plaques have become very hard. So this is the instrumentation which we have for treatment of coronary artery occlusions. And initially everybody had those apprehensions that interventional cardiology doesn't work, it has many problems, and this all in fact started when the first catheterization was done. The doctor was actually fired and he became a gynecologist or a general physician when he did the first catheterization, but later on in his life he was given a Nobel Prize in 1956. So initially every technology has those initial hitches, but now it has been perfected to a great extent. And this is a gentleman who did the first angioplasty, and this was only in 1977, and this is how angioplasty was done. That a blockage which is there in the artery, a balloon is taken inside, it is expanded, and when the balloon is taken out, the vessel becomes opened up and the blood flow is restored. And this is the stent which I showed you earlier, and the first stent were implanted in 1987 only. This was the bare metal stent, and at that time we started knowing that interventional cardiology or angioplasty is effective, and the stents were found to be effective compared to ballooning only, and showed that the reblockage rates were low, started decreasing by the use of stent implantation in coronary artery blockages. But still there were some reblockages occurring at that time, and that is when the surge of or resurgence of these stents came in with the drug-eluting stents, where drug was coated on the stent surface, which used to get released over a period of time, and this was in 2003. And as you will see here, this is the representation of a stent implantation inside a blockage in the coronary artery. The stent remains in the artery for the entire life thereafter. It doesn't move, and the drug which is on the stent surface keeps getting released over a period of about 2 to 3 months. And that is what actually prevents reblockages in these arteries. So this is all about the drug-eluting stent, and the results which came from drug-eluting stents, as you can see here, the reblockage rates became very less compared to the stents which did not have drug coatings, and these were the initial studies using the two types of drug-eluting stents, using a paclitaxel coated stent and a sirolimus coated. Sirolimus was the drug which was coated in one of the stents, and paclitaxel, these both drugs were being used for renal transplant patients and cancer chemotherapy, and the dose which was used in these stents was very, very minimal. So there was no side effect or any toxicity with these stents. So that is what we call now as the DES or euphoria, or a drug-eluting stent euphoria, that all those patients where we were putting stents started getting drug-eluting stents. The advantage of drug-eluting stent was that the restenosis rates started becoming very low. There was improvement in target revascularization, and the only little problem is that the patients have to keep taking antiplatelet drugs for at least 1 year time, and there is some little chance of stent thrombosis if they stop taking antiplatelet drugs, especially in the first 1 year or maybe first 2 years. And although it is costly, but still we say that it is cost effective because it is very easy to use, and the patients are up and about in a very, very short time. So historically, by